Bismillah ar-Rahman ar-Rahim. Good morning, good evening, according to your time zones. Hello, everyone. My name is Hisham al-Khatib. I am a consultant radiologist, and I will talk about the ultrasound imaging of testicular masses overview. Alhamdulillah, wa salatu wa salam ala rasulullah wa ala alihi wa sahbihi wa sallam ajma'in. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. اللهم أخرجنا من ظلمات الوهم وأكرمنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم. اللهم ارزقني نعمة الإخلاص لوجهك الكريم بكل ما أقول وبكل ما أفعل آمين يا رب العالمين. I have no financial relationship to disclose. My objectives is to review the ultrasound equipment needed and examination technique and to review the various type of testicular masses and ultrasound findings of these testicular masses with examples. Ultrasound examination, the room should be warm and used warm gel. Scrotal ultrasound is performed with the patient lying in a supine position and with the scrotum supported by towel placed between the thighs and the second towel to hold the penis. Optimal results are obtained with a probe 9 to 15 megahertz high frequency linear array transducer and scanning performed with the transducer in direct contact with the skin with copious amount of gel. If necessary, stand-off pad can be used for evaluation of superficial lesion. The testes are examined in at least two planes, the longitudinal axis and the transverse axis. The size and echogenicity of each testis and epididymis are compared with those on the opposite side. Color Doppler and pulse Doppler parameter are optimized to display low velocities and demonstrate the blood flow in the testis and the surrounding scrotal structures. Color Doppler ultrasound should include comparison of bilateral testicular spectrum tracing. Power Doppler ultrasound may also be used to demonstrate intratesticular blood flow in patients with acute scrotum, particularly in evaluation for torsion or infarction. As I said before, high frequency probe, linear array from 9 to 15 megahertz. Doppler capabilities is essential with full wall filter, lowest scale, and high possible power output and optimal gain. Start with normal testis. Comparison view is important. Grayscale and color Doppler appearances and don't change the parameter. Long axis, short axis is a measurement. Testicular cancer is screening is accurate. We can screen for testicular cancer via the testicular self-examination, and it is low specificity. About 8% of men with lump found to have a tumor. And testicular ultrasound is important and it is high sensitive and specific. Here, some no-touch lesion, and I will discuss some of them. Prominent septation. Testis can be divided into lobules, as we see here. The lobules are separated by septi, and we should use at least 7 to 14 megahertz probe no palpable mass, and because due to sound hitting the septation and the reflection away from the testis, giving the appearance of pseudomass, as in this example. Mediastinum, it is a fibrofatty tissue crossing direction traversing the testis, contain nerve vessels, seminiferous ducts. In some cases, it is echogenic with some acoustic shadow. This is the mediastinum. And vascular channels, classic appearance of testicular artery, it is circumferential around the testis, perforating vessels at the level of the mediastinum, and not frequently seen a horizontal vessel as in this example. Retitestis, it is a coalescence of seminiferous tubules at the level of the mediastinum here, and it is bilateral, more or less symmetrical, avascular, and it is not bulbable, and it is a retitestis. Might be due to obstruction of the epididymis or efferent tubule and increase after vasectomy, and may be associated with epididymal cyst. Here the retitestis and the epididymal cyst. Zebra or striated testis due to fibrosis and subsequent atrophy seen in the elderly patient with diabetes, with atherosclerosis, or diabetic patient and radiation to the testis. As we see in this example, striation involving the left testis in this patient. With ultrasound, is there any testicular malignancy? If we have solid mass, complex mass, and the mass is palpable and it is high malignant suspicion. If we have solid mass and complex but not palpable and it is intermediate malignancy. If we have simple cyst but not palpable and it is very low significance of malignancy, and if we have simple cyst but palpable and very low malignancy. As we know, the testicular pathology can be focal or can be global, and the primary testicular pathology can be due to neoplasm, infarction, infection, or trauma. The testicular masses can be solid and can be cystic, and can be hypo, and hyperechoic region. On the grayscale ultrasound, it cannot be differentiated. As we see here, we have a grayscale ultrasound of 4 patients. All of them have a hypoechoic mass lesion, and we cannot differentiate these masses, which one is a tumor. But if we add clinical history and add Doppler, we can also able to differentiate. And here the mass lesion in this patient, hypoechoic with intratesticular Doppler, it is a tumor, and this patient has no intratesticular vascularity, and this patient has an infarction. This patient has an abscess with increased testicular around the abscess, and this patient has a trauma with hemorrhage appear hypoechoic with no intratesticular vascularity. So history and the flow are very important to differentiate pathology, as I explained in the previous examples. The classification of testicular tumor can be primary and can be secondary. Primary tumor can be due to germ cell tumor and non-germ cell tumor. Secondary tumor can be lymphoma, leukemia, and metastases. Primary tumor, 1 to 2% of male cancer. Number one cancer between 15 to 35 years old. 2% are bilateral and 90% are cured. Some predisposing factor for the testicular tumor, prior tumor, Caucasian, family history, undescending testes, infertility, microlithiasis, intersex hormone like Klinefelter syndrome, and testicular feminizing conditions. Germ cell tumor, we have two types. We have seminoma and non-seminoma. The seminoma is about 40 to 50% of the germ cell tumor, and it is between 30 to 50 years, less aggressive, radiosensitive, and no elevation of the alpha fetoprotein, but 5 to 10% has increased HCG and increase in the undescending testis. Non-seminoma, approximately 50% to 60%. We have subtypes, mixed embryonal teratoma, choriocarcinoma, others, and the tumor markers are elevated in about 70% of these patients. Here, with this table, we have different types of tumor with ultrasound and the age of representation and the hormonal markers. The seminoma, we have the classic type is more common, and we have the homogeneous hypoechoic mass with intravascular testicular increased vascularity, and this is the classic representation of ultrasound of seminoma. Sometimes it is heterogeneous. Here, another patient with seminoma with hypoechoic and increased intratesticular mass vascularity. Here, another patient with heterogeneous mass with seminoma involving the left testis. Associated with lymphadenopathy. The non-seminoma tumor, it is more common than seminoma, and it is between 30 to 40 years, usually larger tumor, heterogeneous, has cystic or calcified component, more aggressive, and have 50 to 75% have metastasis, and less radiosensitive. As we said, we have more than one type, and tumor marker are increasing about 70%. Here, patient with heterogeneous mass with anechoic and increased vascularity, and evolved to be non-seminoma tumor, mixed germ tumor, choriocarcinoma, and teratoma. Here, another patient with large heterogeneous tumor with increased flow, mainly in the involving the left testis, and the patient has alpha fetoprotein, and the patient age is 22 years old, and it is the mass, it is infiltrating the tunica, uh, tunica vaginalis and involving the epididymis. And this is proved to be mixed germ cell tumor. And this patient also has metastases to the lungs with multiple nodules, as we see. Another patient, 31 years old, with left testicular mass, heterogeneous with anechoic uh, areas with increased vascularity, and it is mixed germ tumor, predominantly yolk sac type. Here, another patient with the patient has previous examination in 2008, and we have the mass, it is smaller compared with the mass and after 4 or 5 years. Another patient, we have this patient has mass lesion here, the same patient. Testicular non-germ cell tumor, it is about 10% of primary tumor of the testis, and it can be sertoli cell and Leydig cell, granulosa, and fibrosarcoma. As we see here in this patient, we have hypococ mass and with increased vascularity. The patient has trauma, and we are thinking the mass could be in the differential diagnosis of the mass can include the AVM and intratesticular varicocele or tumor. And the patient has a previous removal of the right testis. Sorry. And the mass proved to be sertoli cell tumor, and it is a rare tumor, and it is around 1% of the testicular tumor seen in children and in newborn, and result in feminizing hormone secretion, estrogen, and gonadotropin associated with other abnormalities, Klinefelter, Peutz-Jeghers, and Carney complex. Ultrasound, it is a small, well-defined hypococ mass with may have calcification or necrosis or hemorrhage and with increased vascularity. Other testicular focal mass lesion, we have simple cyst, as we see here. Simple cyst, usually non-bulbable, and it is incidentally discovered and you require no treatment, as we see in the ultrasound finding of the cyst. Careful inspection is warranted to differentiate this tumor from testicular neoplasm, especially cystic teratoma. Here, the patient with mass lesion, 25 mass lesion with onion skin appearance with fibrous tissue surrounded, and this is the classic appearance of the epidermoid cyst. Epidermoid cyst, cystic cavity lined by stratified squamous epithelial. As I said, it is onion skin appearance or the classic type, the classic ultrasound presentation with alternating layer of keratin and desequamated squamous cells. Here, patient 9 years old with 29 years old with infertility, and we see here multiple areas of the hypoechogenicity involving the right testis with some increased vascularity and testicular biopsy proved to be Sertoli cell tumor, Sertoli cell only syndrome with no evidence of spermatogenia. And this is the patient, right and left testis with multiple lesions and Sertoli cell only syndrome. It is also called germ cell aplasia, and patient has no sperms and present with infertility. And the usual presentation between 20 and 40 years with infertility with isospermia. Here, a patient 9 years old with bilateral, more or less symmetrical hypoechoic masses around the mediastinum with some increased vascularity. The differential diagnosis bilateral germ cell tumor, lymphoproliferative disease, metastasis, but the clinical history is important in this patient, congenital adrenal hyperplasia. So the ultrasound, this is the testicular adrenal rest tumor, and the testis may be or maybe not enlarged. And as we see here, bilateral solid masses hypoechoic with hyperechogenicity due to fibrosis. Follow up with the treatment, and the masses are decreased in size. Hyperplastic adrenal rest found in the disease with high serum level of adrenocorticotrophic hormone, like in congenital adrenal hyperplasia, Addison, Cushing, adrenogenital syndrome, and these lesions represent hyperplasia of Leydig cell and adrenal rest from the embryonic time when testis located in the retroperitoneum. And the histology of Leydig cell from the hyperplastic can be difficult. Treatment with cortisone does not necessarily improve the presence of a tumor. The main differential is leading cell tumor are malignant in 10%. Patient here presented 40 years old with acute pain, but no palpable mass. Ultrasound, we have a mass lesion with no vascularity involving the superficial part of the testis, and it is infarction, segmental infarction in this patient. Another patient with 38 years old with involving the left testis, and the patient has a scrotal mass and the differential multiple lesion involving the left testis. The patient cannot be exclude the lymphoproliferative disease, but the patient has TB and discharge on anti-TB treatment and improved dramatically. This patient has increased vascularity of the testis on the left side, suggestive of epididymolysis, and this patient has epididymolysis on the orchitis on the left testis, of the right testis, and another patient with orchitis on the left testis, and another patient with uh, orchitis with abscess formation on the left side, and some inflammatory changes on the skin with increased infection. Another patient with multiple uh, abscesses with this patient with orchitis. Testicular microlithiasis on ultrasound seen uh, discrete punctate non-shadowing between 1 to 3 millimeter with no shadowing, and the majority has infection or trauma. Maybe the responsible for that is the ultrasound with transducer. High ultrasound with transducer is the modality of choice, more than 7.5 megahertz. There is controversy about the presence of microlithiasis alone. If there is any risk factor, other risk factor, follow-up is advisable. If there is no risk factor, it is no need to follow up. Germ cell tumor, it is reported to increase in these patients in absence of mass lesion. In conclusion, high resolution real-time ultrasonography has high degree of accuracy and sensitivity in the detection and characterization and localization of scrotal lesion, making the undisputed modality of choice for imaging of the scrotum. Solid testicular masses with internal increase vascular flow must prompt high level of suspicion for testicular malignancy unless an equivocal imaging findings suggest benign diagnosis. My references here: سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك. Thank you very much for listening.